Good afternoon, dear students. Today we'll talk with you about how to treat open and closed fractures. So we'll base on the classification of fractures and we'll provide treatment according to the type, location, and severity. So actually today we're going to discuss classification of fractures again, and according to each type, the possible options. So the basic principles of fracture treatment of non-surgical way involve functional treatment as functional bandages and skeletal traction, as well as immobilization method. It means fixation of a fracture with different types of bandages. And surgical treatment, when we use different implants, that's actually internal fracture fixation, external fracture fixation, and the different combinations. So we'll focus with you on indications for these surgeries, possible merits and demerits, and as well as rehabilitation of the patient after such treatment. We know that when we have a fracture which is not displaced, other ways to name this fracture is hairline fracture, or fracture which was impacted fracture, or not displaced fracture. So everyone understands that this may be the simplest one, but we should take care about it. And when this type of fracture occurs, we say that the force was big enough to cause a fracture of the bone tissue, but was not too big to cause the further displacement of bone fragments. So when we have such type of fracture, we should check clinical symptoms, and for non-displaced fractures, you won't see any deformity. You won't see pathological mobility and crepitation as well. So you should apply axial load, and in this case, your patient will feel pain in the fracture side. So then you'll go to X-ray, and you should make AP and lateral view at least. For some locations, a scaphoid bone fracture, you need to make 3 views, 45 degree for scaphoid. We'll talk about these peculiarities later on. And then when you see the fracture on the X-ray, you should immobilize it. That's actually what fracture needs. You should immobilize it for a certain period of time that needed for fracture healing. You shouldn't interrupt your immobilization. It's not like immobilizing for 1 week, then removing POP bandage for a few days, and apply it again. No. You're applying it once, and you're not removing it until the fracture has healed. For this sense, you should know average periods of time that every fracture needs for healing. So if we're talking about this type of fracture as metatarsal bone, which is not displaced, the second metatarsal bone. So we're talking about 3-4 weeks of fixation by POP bandage is enough. Doesn't require circular bandage. This posterior cast can be applied. Of course, you're fixing the foot and the lower third of tibia. On the right side, non-displaced fracture of tibial shaft also should be immobilized for 4 weeks to heal it. After this, fixation can be removed. Patient can start load on this limb. So very common question is that actually what may happen if the fracture like this one, non-displaced, is not immobilized. So depends, of course, from the location, but the most obvious answer is the fracture can become displaced. So the patient can apply some load on this place and cause the displaced fracture, especially it is possible in 2-3 weeks when resorption of this part of of tissues around the fracture occurs, and in this case, for spongy bones, and in these cases, the further displacement can occur. That's why, in all cases, you should apply brace or cast or POP bandage for non-displaced fractures. Let's go on. And next type of fracture that we usually see in childs, we call it a green stick fracture. So this is a fracture which usually is displaced like angulation. So of course, you should correct this angulation. And remember, every fracture needs to be immobilized. So you should apply a POP bandage, polyurethane bandage, scotch cast, or brace. But before you should correct the displacement. And for these scenes, you should know that as acceptable displacement that you can keep on, and there's non-acceptable displacement. That's non-acceptable means that if it will heal, it will be wrong position, malunion, and later the function of this part of the body will be impaired. That's why you should correct it to improve further outcome. Okay, that's why there's some acceptable displacement for each location. And if it is displacement like a few degrees, like 1 or 2 or 3 degrees, maybe it is acceptable. But if it is a displacement of 20, 30, 40 degrees, roughly talking, it's not acceptable. It should be corrected. And after this, POP bandage should be applied. So next type of fracture you see here, it is a transverse fracture. So according to this fracture type, fracture pattern, we see that the fracture plane is quite small. So bigger fracture plane, we have more contact between bone fragments, and we have more rigid fixation when the fracture is healing. For transverse, it is less. And another peculiarity for this fracture is when it is fully displaced, so it should be reduced in all ways, because if it is fully displaced, there's no contact usually between bony fragments, and there is such types of shortening as well. So, but when this fracture is reduced and plaster bandage is applied, usually it is not displacing again because of fracture type. That's our peculiarities for these scenes. And another scene is that comparing with oblique fracture line and the comminution fracture line, these fractures may heal longer. That's why in many cases we use a surgical method. So for transverse fractures, intramedullary nailing of these bones, or maybe plating, compression plating is a good choice. So for unstable fractures, we usually combine 2 techniques. First period, we apply skeletal traction until the soft callus is formed, and then we can apply a POP bandage till the end of the fracture healing process. So if we talk about comminuted fractures like that, we also consider them as unstable fractures. So they have many chances to be displaced in plaster of Paris bandage. And if it is fixed, immobilized well, so usually we don't expect problems with healing because we have a big fracture line, and usually big hematoma is formed in this area, and all these bone fragments are involved in the hematoma and in the callus. So actually there is no need to fix each of these small fragments to the main one. But if we have a double fracture, means that fracture line in 2 places, proximal and distal, that's a case when we have problems, because this part, middle fragment, is usually without blood supply. And not rare cases are when the fracture is healing in one place and another place without blood supply has non-healing or even formation of pseudoarthrosis. Another case is when we're talking about fracture which is open. So that's usually with severe displacement. First of all, we need to, when we're providing a first medical aid, we shouldn't reduce this fracture at the site of accident. We should just apply a splint as it is. Then we should take it to the hospital. We should clean it thoroughly. Then we're reducing it and apply external fixator. Next type of fracture is common for spongy bone. It is impacted fracture. So common for femoral neck, humeral neck, some other locations when a distal segment is driven into the proximal one. Usually there is no significant displacement, and that is good. And we should just immobilize this area and fracture will heal. So for femoral neck fracture, we have two options. We may allow patients bed rest for 6 weeks and then partial weight bearing for 6 weeks. Or we can fix it with some screws that will prevent the displacement. Because if in 2-3 weeks approximately, the resorption of bone tissues edges of this fracture occur and some load will occur, so the fracture can be displaced, and then more complicated and more expensive treatment will be needed. So spongy bone we have in calcaneus and we have in bodies of vertebrae, and these two fractures are very common for falling from the height. So usually the height of this bone is decreased, and starting from the first minutes we shouldn't allow this patient to sit up or stand up. We should put them in the on the hard surface in horizontal position, and within all the treatment you should keep the patient in horizontal position. Depending from the degree of the fracture, for first degree we're talking about 1 month, second degree 1.5, 2 months, and the third one, the most severe compression, we may keep the patient in bed for 2.5, 3 months. We need reclination, we need physiotherapy, we need analgesics. But when we're talking about severely fractured fractures, like the third degree, mostly, sometimes the second one, the transpedicular fixation surgery can be considered. If we talk about calcaneus fractures, usually also the shape of this calcaneus is changed, but the main problem is the joint between the talus and calcaneus. If the Baylor angle is decreased or become negative, we should correct it and we fix it with plate, with screws, with K-wires. But if you fix it with the K-wires, we need additional plaster of Paris. Avulsion fractures on the right side of the base of the fifth metatarsal are caused by sudden contracture of the muscle, and usually we just need to immobilize this fracture if it is non-displaced or there is no significant displacement. As others are fractures, avulsion fractures like Lasseter Hunter, they don't cause severe disability of the patient, and actually no specific treatment is needed. If this patient is going for professional sport, maybe then you can fix it. But in most of the patients, especially old patients, it is not needed. So just bed rest for some certain period of time. If we're talking about joints, and sometimes ligaments are ruptured, or sometimes cause avulsion fracture of the fragment where the ligament is attached. So usually for these scenes, treatment requires reduction of dislocation. We may fix it with a mini screw to the base of the phalanges and of course apply plaster of Paris bandage. Next, fracture pattern is quite severe injury because we're talking about fractures that are involving the joint. So on the left side, we have 3 fracture patterns, and you see that the involvement of joint is different. Here we may have a partial involvement, here we have complete destroy of articular surface, and here we have so-called osteocartilage fragment, so some part of the bone is impressed with the cartilage. So of course, different outcomes we can expect. And the worst outcome we can expect for C-type fracture, according to the AO classification, when we have completely destroyed articular surface. So the main idea of the treatment is to provide for patient as good fixation, say precise reduction of these fragments with a good fixation that will allow patient start early movement. So if we have a displacement just 1 or 2 millimeters, it may be considered okay. But if the displacement is more, we should reduce it, usually by means of surgery. But almost in all cases, we have a higher risk of osteoarthritis. That's why better reduction and early movement will help to prevent this osteoarthritis and to reduce the complication rate. If we look at this slide, on the right side, we have no joint involvement, but the fracture is close to the joint. So actually, when we apply a plaster of Paris bandage, it will also cause problems with joint movement. And when the plaster of Paris is removed, fracture has healed, bandage is removed, usually we have joint stiffness that needs prolonged rehabilitation. This is another pattern. It's quite complicated injury when the dislocation and the fracture is combined. So we should manage 2 problems. We should put the head of humerus on its place, reduce the dislocation, and then we should reduce the fracture and heal the fracture. So normally, you know the techniques for reduction of dislocations. So usually we use this distal part of our arm as a level. We're twisting it and we are rotating it and we can put it on its place. But if it is fractured, it's not possible. So actually, to reduce this dislocation is quite problematic. We can use mode method, lateral. We abduct the limb, apply lateral traction, and then with the first in the axillary region, you can push the head inside. So in many cases, this technique is successful. And then we should reduce the fracture. You may fix it with some K-wires, plate, and actually we need to heal it. Okay. So next type of fracture we call complicated. So because the fracture is complicated with injuries of some internal vital structures like vessels and nerves. That's why actually for every fracture you should check distal blood supply and sensation. If they are decreased, like you have lost sensation or there's no pulse rate, maybe you should perform open revision of the site and to find that part of the bone which is pressing on the artery or nerve and to reduce it in an open way. So actually, our treatment is usually based on such things as fracture locations. If you have metaepiphyseal fracture, it's one treatment. If you have shaft fractures, it's another treatment. And mostly for shaft fractures, we can use intermedullary nails. For metaepiphyseal fractures, we can use plates with screws. We can use screws alone as minimum invasive technique. For shaft fractures, we also can use plates, but for intermedullary nails, we have such benefits as early load can be applied, and actually it can be done as minimum invasive technique. We also should consider the location of the fracture, because for different locations, the same femur, middle third, lower third, upper third, we may expect different displacement types, and we can expect different technical problems when we are trying to operate this fracture. So first of all, we should consider the presence of displacement. And now we'll talk about how to diagnose this displacement. So as we know, there's different treatment for displaced and non-displaced fractures. So this slide shows us how to detect displacement in two planes. So we know the rule for X-rays that we should perform to use AP and lateral. And if we look at the first picture, we see lateral view on the left side when we have a patella on the side, and there is no displacement, anterior or posterior. AP view, like that one, can show us lateral displacement. So actually, on this view, you don't see any lateral displacement. But when you look at the second picture, on AP view, you can see that there is displacement. And actually, distal fragment is displaced according to the proximal one. So as we have on the lateral side, we have the head of fibula here. So this is lateral side, and all this distal fragment is moved to the lateral side. When we look at the on the lateral view, we don't have any shift to the anterior or to the posterior part. The third picture is quite different. So on the AP view, we don't have any shift. So we don't have lateral displacement. But on the lateral view, we have the shift of distal fragment to the posterior side. So actually we have a complete posterior displacement. And the fourth picture shows us both types of displacement. So we have posterior displacement and we have lateral displacement. So that is a fracture with posterior lateral displacement. As we understand, when we are talking about fractures that are displaced, we should put these bone fragments on their normal place. Then we can consider that fracture will heal better. So on the right part of the picture, we also have two types of displacement. On the above one, we see that the displacement is partial. So we have the connection between bone fragments and the fracture will heal. On the lower side picture, we don't have almost no connection between bone fragments. That's why we can consider that that's not good for healing, and we may expect delayed healing or even non-union. That's an example of stable fracture or transverse fracture, but with full displacement. So for these fractures, we need to perform first of all, we need to reduce the fracture site, and then we need to immobilize it with one of the methods like surgical or non-surgical. So if we have the fracture type as oblique, or we have a big plane of a fracture, and actually we don't expect significant problems with fracture healing. But we have problems with stability. And if oblique fracture occurs, usually even some shift can cause the shortening of the limb. That is true about spiral fractures and about comminuted fractures. That's why we can't use plaster of Paris for displaced oblique and spiral fractures. They should be treated by skeletal traction or by internal fracture fixation. As you see, for transverse fractures, you should have a fracture which is completely displaced. Only then you have the shortening. Oblique fractures, it's vice versa. Even some slight shift can cause a significant shortening or extremity. So that's another type of displacement that we should correct. It also is considered as very bad displacement because the function for angulation is significantly decreased. So here we have the angle which is open to the anterior side for tibia, and that is the angle which is open to the lateral side. So we call it valgus angulation. Actually, both these should be corrected for further good functional outcome. And the next type is rotational displacement that can be easily missed. So if the short X-ray is done like proximal part without distal, you may think that everything's okay here. But if you look at the long film, you know X-ray anatomy, that the head is in good, this is AP view, so it is in good position, and the knee joint is rotated because patella in AP view should look like that one. Here we have like 90-degree rotation, internal rotation of the distal fragment. But if you have a short X-rays like that, you can't determine that. So actually you need X-ray from one joint to another joint. Then you can diagnose the rotational displacement. The same on the lateral view. You should have here lateral view, but you have AP view distally and lateral view proximally. That indicates the presence of rotational displacement. So again, in all cases, the rotational displacement, which is more than 15-20 degrees, should be corrected. Here I have an example of open fractures. So we may have a very small wound, and actually in many cases, these fractures can be treated even with plaster of Paris applied. Make some window here, take care about wound. But if we have a fracture with big wound, with bleeding, and of course infection in this place, so we may have it of two types. One, when force was acting from inside out and the sharp bone edge is piercing tissues and skin. And another one when force was acting from outside in, cause the damage of soft tissues and then the bone. So you understand that the severity of bone injury and soft tissue injury will be different according to these mechanisms. So these types of fractures need, first of all, to perform a surgical debridement, removing all dust or infection, crushed tissues, and wash it with a big amount of antiseptic solutions. And also, we need to suture the wound, drain the wound, and stabilize the fracture, means applying of external fixators. So again, about basic principles of fracture treatment. The first point is that it starts at the place of accident. So actually you start with immobilization. You should apply one of the splints that exist. You should give some analgesics. You should, or if there's a wound, you should clean it and you should cover it with sterile bandage. And also you should stop the bleeding. So you should know how to stop the bleeding for different types, for capillary bleeding, for arterial bleeding. You also should apply the limb in elevated position, apply some ice, and refer to the orthopedic surgeon or trauma center. That's our main splints. Actually, we have another video where the splints application is described, but just a few words about the scenes. It's Kramer wire splint. It's universal splint, so you can bend it. You can take short one, long one. You can fix any fracture starting from the shoulder joint to the elbow joint. And actually, you can use it for lower extremities as well. So for upper extremities, you can immobilize forearm fractures and humerus fractures. And if you don't have the splint, you can use a sling. You can use the saw bandage. You can use any material around you, like stick, umbrella, to bend it to the fractured side. That's how this Kramer wire splint can be used for lower extremities. Mostly we are talking about tibial fractures and foot. Yeah, so if you have to immobilize femur, maybe it's not so convenient, but we should use 4 of them, 2 on the posterior side, lateral side, and medial side. But we have special splints for hip joint and femur. So these are Dieterich's wooden splint. So Dieterich's wooden splint has parts which is placed on the inner surface, outer surface. A part for foot, when the foot is attached to the board, and a stick which is used to create a traction. Here's how the splint looks like. And you see the proximal part is bended to the body, distal part is bended to the foot, and you can apply traction. By twisting a stick, you can apply traction over the extremity, which provides better fixation. Then you bandage the seams, the splint to the limb. What may happen wrong if there is no splinting or fracture? So I would say the chance for complication is much higher. So first of all, the patient will have much more pain. Pain will be severe because any movement of this limb will increase this pain. When fracture is immobilized, the pain is usually much less. Especially it is important for many fractures, multiple fractures, and a shock can be developed if those fractures are not immobilized. Second problem may occur when fracture can become open. The bone fragments can damage nerves and arteries. Fat embolism and thromboembolism can occur. And the rate of these scenes is much higher for fractures that were not immobilized. That's why we recommend to do these scenes for all cases. Okay, let's now talk about what can be done in the hospital. And we have 2 big groups, non-surgical treatment and surgical treatment. So I would say that almost every fracture can be treated non-surgically and surgically. So in many cases we have few options. Just very rare case we have only one single option. Mostly we have few of them. But of course, one of these options is better than others. So that's why, but in all cases we have a choice because situation may be different. There may be some concomitant disease, there may be some contraindications for surgery or general anesthesia when you can't perform surgery. That's why you should know what to do in these cases and how to manage the fracture in non-surgical way. So actually, non-surgical treatment can be divided into immobilization method and functional method. So immobilization method, we've talked with you already. It starts from the place of accident. And functional method, it's usually skeletal traction, skin traction, or maybe a functional bandages. And we put here, like for non-surgical treatment, a manual reduction. But you should understand that this manual reduction is usually combined with immobilization method or skeletal traction method, mostly with this one. So first you should perform a reduction of fracture. This means close reduction. And then we should immobilize extremity. If you won't immobilize, this manual reduction is not necessary because the fracture will be displaced again. And of course, when we're talking about drug therapy, it should be combined with also these methods, because just giving analgesics, calcium, won't help to reduce the fracture if it is displaced. So you should reduce it, you should immobilize it, and additionally to these things, you should give painkillers, you should give physiotherapy, you should give calcium, vitamin D, and so on. But it's in this order, yes. So it's on the third place after immobilization and after reduction. Okay, and when I'm talking about a surgical treatment, internal fracture fixation, when we put implants inside of the patient body. And external fracture fixation, actually it's like maybe tricky name because we also put something inside, but that's not all the whole device, but just part of it. Some shunt screws, for example, are drilled in the bone, but the main device is outside. That's why. Okay, and so for internal fixation, whole device is inside. So that's main principles how manual reduction is performed. So we should correct all types of deformities. So we have several steps. The first step, we apply axial traction according to the axis. Then on few minutes, we should correct all types of deformities, shift, rotation, angulation, and then you should fix it. You should apply, fix it in correct position. So you should, we call it a retention. First, you're doing this by your hands, and when the plaster bandage becomes hardened, then you can leave. Then the patient can go home already, but this bandage is immobilizing the fracture within all this period of time. So that's another way how the reduction can be done. What special mechanism? It helps a lot because it is performing first period traction, and then you can perform a reduction by your hands. So you can apply your hands here and correct shift, correct rotation, and also you can apply pupil bandage in this device. So if you don't have such device, you need 3 people, 2 assistants. So one assistant is making traction one side, another assistant in the other side, and you're making reduction. And by means of this device, you can do it alone. The name of this device is Sokolovsky apparatus, but maybe in different countries it may have different names. So which bandages are usually applied? So you see it can be circular bandages and semicircular. Of course, when you perform a reduction, you should apply circular bandage because it provides better stability and it will prevent displacement. And semicircular bandage won't prevent displacement. So semicircular bandage are just supporting the fracture. And usually for non-displaced, for non-stable fractures, it's not acceptable. So it can be used only for those fractures that are without displacement and they have no chances to be displaced in this bandage. And again, we have circular bandage with a window if we have wound here. And we want to take care about the wound, so we can apply this type of bandages. That's POP bandages. Usually we put it in water, rolls, and by means of this we can make different POP bandage of different shape. Yes, we usually apply it in layers, and to achieve good fixation, you need from 6 to 8 layers usually. It takes maybe 5-7 minutes to make this bandage hard, and actually all this time you should keep reduced fracture in its correct position. Only when it hardens, you may relieve your fixation with hand. That's a way how we can manage the POP bandages. We have special sauce here. Actually, now we use not circular sauce, but we use oscillating sauce. They can't damage the skin. And we have special scissors, special cutters that can cut the bandage and release it or remove it. Remember that you may have patients after the hospital treatment. Usually we have, if we're making a reduction, we apply POP bandage, and then next day patient, maybe the same day patient is at home, and the family doctor, physician should take care about him. So you should know what to do with the bandage, yeah. And if you look carefully, circular bandage is applied in such way the distal part fingers, you can watch them, yes. And that's important point, because if the POP bandage is compressing nerves and arteries, there will be loss of sensation. Patient's finger can become pale or even dark, and it indicates that the bandage should be removed, or at least you should cut it and make some release. Because if you remove it, the reduction, the fracture that was reduced may be displaced, yeah. But if you just cut it, the circular bandage, you cut it, it will make some slight release. In many cases, that is enough. That is enough. But you should watch your patient. If the fingers are warm already, the sensation was restored, well, that's okay. If not, you should make more release. Or even if you see that it won't help, you should remove it, because it's much better to remove POP bandage and fingers will have blood supply and will be alive than to keep a good reduction, but you may lose all arm. Yes. So actually, that's why first thing, remember that circular plaster bandage is a very dangerous thing, and it requires continuous care, at least within first days when the swelling is increasing. And a second thing that it is applied in such a way that you can monitor the condition of blood supply and innervation. Okay, let's move to the functional fracture treatment. And here we have different types of traction. It's easy to remember, like if it is traction is applied to the bone, like KY is drilled through the bone, then it would be skeletal traction. So that is the most common type we used in the hospitals. There may be glute traction or adhesive traction when slings are attached to the skin by glue or adhesive strips. Usually, of course, it's better. You don't need to put something inside. You don't need to drill the bone. And soft tissues aren't lacerated, but you can't apply big weight here. You may apply just maybe 1 kilogram, 1.5 kilogram. But if you need 5, 7, 10 kilograms, that's only for skeletal traction. And usually to reduce the fractures, we need big weight. So that's why main type is skeletal traction, and this can be additional types combined with the skeletal one. And also maybe a sling traction that we use as additional way to correct fracture positioning. Let's see a picture of our upper extremity treated by means of skeletal traction. We can treat humeral fractures. We can treat glenoid fractures of this one, of scapula. But actually, mostly we use it for unstable fractures of humeral shaft, supracondyle fractures, and neck. So method is inexpensive. By means of it, you can correct all types of displacement, but patient is attached to bed for months. So it's a disadvantage. So we don't use it for all people, with abused people, with when bed sores can develop, but usually for young and middle-aged people, patients, it's okay. So you can see that the place where KY is applied is olecranon. It's a main pulling force here. But we have additional one. It is a skin traction, yes. Adhesive strips are used to apply skin traction. And not big weight is used here. And you see additional sling is applied here and is pulling lower third of humerus laterally. And here is an X-ray. The sling is applied here and it is pulling it laterally. So it corrects the axis of extremity. So actually that's easy. You should apply the force to those areas that are displaced. And that's additional side force that can correct the displacement. Actually, you're waiting for 3 to 4 weeks. Then we have a callus formation. It starts forming. So we can remove it and apply POP bandage for 2 months more. That's lower extremity. Principle is the same. You just need to know the places where the KYs are inserted. That's supracondyles, tibial, femoral supracondyles area, and tibial tuberosity for femur and hip joint, and calcaneus or supramalleolar region for tibia. That's additional slings can be used, side slings, one side, another side, but main traction is applied through the bone, through skeletal traction here, according to the axis of the tibia. And some additional slings can be made for foot as well. That's the scheme for main places where KYs are inserted. So olecranon, supracondylar area, tibial tuberosities, supramalleolar area, and calcaneus. Now let's go to surgical treatment. We have just 10 minutes, I think. So main points. First of all, we can perform close reduction. We can perform open reduction. We can perform internal fixation. We can perform external fixation. So these 4 things can be combined. Like close reduction can be combined with internal fixation or with external fixation. The same open reduction and be combined with internal fixation, which is usually down, and sometimes with external fixation. Note that we can use plates called plating, intramedullary needling, and reduction osteosynthesis when we use small devices just to put this bone on its place, but not a very rigid fixation. So usually when we use reduction osteosynthesis, we use external fixator additionally, or we can use PUP bandage. That's actually all surgeries, all osteosynthesis that we are doing for fractures are in this scheme. So main advantages and disadvantages you should know. So of course, internal fixation can provide better reduction. So you can reduce, if it is articular surface, you can reduce it precisely. If it is articular surface, it can be immobilized and joint can be movable. For disadvantages, we're talking about high risk of infection, we have a risk of general anesthesia, we have to remove this device later in most of the cases. That's why we also have some disadvantages, and of course, usually higher costs for surgical treatment because implant is needed and some additional materials are needed for the operation room. So actually, but rehabilitation is much quicker. So have merits and demerits. Okay, we have some indications. So here we have strict indications like intra-articular fractures which are displaced should be operated, and relative indications such like you can treat some fractures like surgical ways or maybe non-surgical way, depends from the patient, from its condition, from the instruments you have, many other things. So actually many cases you can choose a surgical method like a relative indication to improve and make more quick rehabilitation for this patient. So main devices that we use, these are K-wires, screws, plates, intramedullary needles, and new devices that we start to use biodegradable pins and screws. So still biodegradable plates in orthopedics are not used acceptable because still are in development. But if we talk about stomatology, about craniofacial surgery, they use mini plates made of biodegradable implants quite a long period of time. So there's something like noise here. I'm not sure why is it so. I have the noise. Actually, I think that we should end the lecture already. Just maybe a few pictures about the screws and plate principles, and I think that will be all for today. Okay. Do you hear some noise here? Because maybe it's from me. Okay, so here we have some certain types of screws. So they may be of different diameter, first of all. We have common types like 6.5 diameter. We have 4.5 diameter for big segments like femur. For tibia, we can use, for radius, you can use 3.5 diameter and 2.7 diameter. And mini screws, like 2.0 diameter screws, is used for fingers, for each joint. Such big diameters, 6.5, 7.0, are used for neck, femoral neck fractures. You can see that screws may be cortical screws and maybe spongy bone screws. So cortical screws have tiny thread, and cortical bone screws, spongy bone screws have bigger thread and better patches in the soft tissue. Also, we have inner diameter and outer diameter. So usually to insert the screw, we should drill with a drill bit with the inner diameter and then tap the screw, tap it and insert a screw of higher diameter. Then it will be parted well in the bone tissue. Otherwise not. We also can have partially threaded screws. We have thread here, and there is no thread here. When you insert in these screws, the compression of bone fragments usually occurred. It is usually needed for malleolus fractures, for femoral neck fractures. That's why we have it for 6.5 screws. Okay, so that's the main principles for them. How they can be used? They can fix together oblique plane, but we can use leg screw. So partially threaded screw, or we can use leg technique. We can compress condyles, usually tibial condyles here, femoral condyle, maybe humeral condyle as well. So we may use K-wires, and that's a Weber technique is illustrated there, or maybe used as a bundle to fix a shaft fracture. And we may use these screws to fix a plate. This is a bridge technique. So this is like a river, one bank and another bank. No, there is no screws here. Some screws are inserted in proximal segment, others in the distal segment. So here we have this bridge technique. So the screws may be of different types. We may have reconstruction plates that can be bended in all planes, yes, in frontal and in sagittal plane. You can have a plate that repeats the shape of the bone, supporting plate for condyles, anatomically pre-bended, pre-shaped plates. And we may have plates that are fixing the fracture in one plane and fixing the fracture in two planes. So note that this plate, we have screws inserted in one plane, and this part of the plate, we have screws inserted in another plate. So actually this is a rotation plate by Rublenik that was invented in our department, and actually it can be fixed for many fractures. Provide very good fixation. So I think, guys, we have just 3 minutes. Main principles of dynamic compression plates. So if you look at this plate, you will see it's a hole. It has a specific design. We have special slope here. And when we insert in the screw, we usually do it not at the center of the oval hole, but we are doing this eccentrically. So the head moves along the slope and make a compression the fracture site, because it moves one bone fragment to another one. This is not a big range of motion, maybe just a millimeter or two, but usually this simple technique allows us to provide compression. Before, the technique was done, there is no scattered but a special device, compression device, yes? So the technique was done in such way, and the plate was applied and one screw was inserted from one side of the fracture, here's the fracture. And then special compression device was used, and we were making compressing this area, and then we were inserting screws. Now, by means of this dynamic compression plate, it was changed, and you insert in one screw, and here you inserted eccentrically a screw in the oval hole. And when you're tightening these seams, the gap between fragments is decreasing. When it is decreasing, it means that we have chances for direct healing, because we need a gap of 100 150 micrometers for direct healing. So if you have more, direct healing is not possible. That's why by compression we can achieve this small gap and we can achieve direct healing. But another condition that we need very good fixation. We need rigid fixation. And if you insert just 2 screws, you won't have a rigid fixation. So you need to insert at least 3 screws on each side. And here is the picture, shows you 3 screws on one side, 3 screws on the other side, and you have a compression, so you can expect direct healing for this fracture. That was about dynamic compression plates. And we have a new generation plates. When you see there is a combination holes. This hole is for compression. When you insert in cortical screws, you can achieve compression. And this one has the threads, and the head of the screw has thread. So it is a locking head screw, and fixation between the screw and the plate is very firm, and the stability of fragment is also very good. And this new design allows us to provide very good stability even for those fractures that are in osteoporotic bone and old people. But nowadays, practically saying, we use this plate for young people as well, as it allows us to provide minimal invasive plate osteosynthesis, like nipple technique. So we are making small incision above, we're making small incision below, we're putting this under the fascia, and we are fixing screws above and screws below. So actually not opening the fracture site. And that's, of course, is beneficial for fracture healing. So thank you very much for listening. That's all for now. Goodbye.